The main contents which will cover this topic is to define the grading and staging of the tumor and to define the cancer cachexia. And this topic is very important that we have to classify the paraneoplastic syndromes according to their clinical effects and association with various tumors. And the last one, that is the laboratory investigations which are used for the diagnosis of the tumors. This is also very important in this topic. We will discuss the different types of laboratory investigation, how we are going to diagnose the cancer. Grading and staging of the tumor are basically the important parameters, or we can say these are basically the methods which are needed for the histopathologist or the clinician, surgeons or oncologists. With the help of these methods, these clinicians are going to determine the aggressiveness of the given tumors and to know about the extent and spread of the patient with the diagnosed with the particular tumors. And these states are also very necessary for making an accurate diagnosis and to know about the prognosis of the patients. So now you come to know that what is the clinical significance of grading and staging of the tumor. For example, if we take the example of the tumor of the thyroid, if the one patient is given like the diagnosis with a well-differentiated thyroid cancer and other one with the thyroid cancer having the diagnosis of the anaplastic carcinoma, so the surgeon will come to know that the well-differentiated thyroid carcinoma have somewhat good prognosis as compared to the anaplastic carcinoma. And in the next slide, we will discuss what are the exact parameters on which we are giving the certain terms like well-differentiated, moderately, and the anaplastic carcinomas. So these terms have a particular importance in the prognosis of the tumors as well as in the treatment options. Okay, grading of the tumor is basically come from the histological report. The grading of the tumor is usually done in the histo lab by the histopathologist, and there are some parameters on which we are going to label the tumors as the well-differentiated, moderately differentiated, or poorly differentiated. So these parameters are the degree of the differentiation. What does it mean? The differentiation means the resemblance to the original tissue morphology. So as much as the tumor resembles to the original morphology of that tissue, it will be labeled as well, moderate, or poorly, depending on the morphology, what exactly it is showing under the microscope. Now, the second important parameter is the number of the mitoses. Some tumors are giving like the 2 mitoses per 10 high power field. Under the microscope, the histopathologist is going to search and count the mitoses per high power fields. And the third category, that is the architectural feature. The tumors are showing some particular architecture like papillary architecture, follicular architecture, diffuse, sheet-like, somewhat different types of the architecture we can see with the tumor. So according to the differentiation number of the mitoses and architectural pattern, the histopathologist is going to label this as a well differentiation and a moderately differentiated tumor or the poorly differentiated tumor. And the histopathological report will show it as GX, as the grade cannot be assessed. This is usually in the small biopsies or crash biopsies in which the histopathologist is unable to label it as the grading. And the other category, that is the G1, this is known as the well differentiated. G2 is moderately differentiated, and G3 poorly differentiated, and G for undifferentiated. Okay, these are the parameters which are applicable in most of the in epithelial tumor. But there are some exceptions do occur when we are going to grade or classify the soft tissue tumors. These are mostly the sarcomas. We have difficulties in classifying in grading of these tumors that are the sarcomas. In case of the sarcomas, these parameters like degree of the differentiation, number of the mitosis, architecture patterns are completely helpless, and these parameters are usually not helping the pathologists in grading of these soft tissue sarcomas. So we will choose the other option in case of the soft tissue sarcomas. Staging of the tumor, it is also needed to determine the prognosis of the patient and to know about the treatment options. This is basically done by the histopathologist and the surgeons. And staging of the tumor, it depends mainly the size of the lesion and the size of the lesion. For example, if the size is smaller, then it is usually comes in the lower stage, and if the tumor size is more, then it will becomes in the higher stage. And the extent of the spread, if the tumor have involved the one organ or multiple organ involvement, in the second one, that is extent of the spread, it means the locally how much the spread of the tumor is present. For example, the size of the tumor was 2 centimeter previously, but when we are going to stage the tumor for about 1 or 2 months later by giving the chemotherapy or other option, but if it is in the failure, then we are going to judge that how much the tumor is extended from the original size. Then we are going to measure the local parameters, that is to measure the local size of the tumor, and then how much it is locally spread to the other tissues or organs. And the second one is the regional lymph node. For example, if the tumor is of the neck of the tumor, or the tumor is the thyroid, then the regional lymph nodes are usually judged, like cervical lymph nodes or the axillary lymph node. The nearby lymph nodes will be judged for any metastatic. If the tumors are involved, like one tumor involved, one lymph node involved, 2 lymph node involved, then the staging will be changed according to the number of the lymph node. Then the fourth one is the metastasis of the tumor. This is also a very important topic, that the how much multiple organs are involved in the tumor. For example, the tumor of the uterus, like carcinoma, if it has metastasized to the lung, so the prognosis of the tumor is extremely worse. And for this staging of the tumor, for this important parameter, we are going to use the current staging system, which is the American Joint Committee the Cancer Staging, and this system will denote it as T capital, N capital, and N capital. So this system is known as TNM system. And in the TNM system, the T will primarily shows the tumor size and the site where the tumor is located and how much the tumor is measured. The N will denote as the lymph node, N0 will show the 0 lymph node involvement, N1 means regional lymph node, the first or one lymph node of the regional lymph node will involve, N2 means 2 lymph nodes are involved. M means metastasis, M not or M0 means no organ, no any other organs are involved, no metastasis is present. And M1 means that one organ is involved, or M2 is a multiple, two organs are involved. Okay, and now coming to the cancer cachexia. Cancer cachexia is basically a multifactorial host phagocytic syndrome that is characterized by a continuous decline in the skeletal muscle mass with the fat loss. So the two important features which you can see in this definition, that is the decrease in the skeletal muscle mass with the fat loss, means the thin physical characteristic. And there are the multiple factors which are involved in this loss. And usually this we can see these are known as the hidden means usually the patients have the cancer, but these are acting as an iceberg. You can imagine that the tumor is so much deteriorating the patients internally, and it leads to the progressive functional impairment, weakens the effects of the chemotherapy, and increases the mortality in the patients with the cancer. So the cancer cachexia is a very important symptom. You can see it's basically a symptom which the surgeon can pick up from the patient. The patient's continuously losing its weight and complaining of what we can say the appetite loss and other sign and symptom. So usually the surgeons and clinical can think about the underlying disease, and they will investigate thoroughly the patients, and this symptom will come to the very much helpful to reach the definite diagnosis. Okay, paraneoplastic syndrome is basically we can say it's a symptom or a disease that is a consequence of a cancer, but not due to the presence of local cancer cells. It's basically a paraneoplastic syndrome is mediated through cross-reacting antibodies or the production of physiologically active factors, or maybe due to interference with the normal metabolic pathways, or maybe the cause may be unknown or idiopathic. So we can say that these are basically the sign or symptoms which are produced and due to the cancer, and these occur in about 10% of the person with the malignant disease. So, despite their relative infrequency, the paraneoplastic syndromes are very important to recognize, because they can be the earliest manifestation for any hidden tumors, or they can be the affected patient may represent significant clinical problems due to these paraneoplastic syndrome, and even they can be more lethal and can be dangerous for the patients. So this is very important to recognize these paraneoplastic syndromes. And third one, that they may mimic the metastatic disease. And so it's very important to recognize these paraneoplastic syndromes. And the table of the paraneoplastic syndrome is basically given in the Robbins. The table is 7.11, and in this table the different types of the clinical syndromes are given with their major forms of underlying cancer, and also the mechanism, or we can see what the exact etiology is we can say is known with these clinical syndrome is also mentioned in these. For example, the first one, that is the Cushing syndrome. This is the syndromic presentation in the small cell carcinoma of the lung. The tumor is hidden in the patient in the lung, but it may be the first manifestation, like the patient present with these syndromic presentation. As we know, what are the exact signs and symptoms of the Cushing syndrome? And you can see the serum level of ACTH are also increased. So the exactly it's how, or we can say that it may be like ACTH like substance. So the patient with this tumor and presenting with the Cushing syndrome, and so we can say this is the paraneoplastic syndromic presentation. Other syndromic presentations are also given in your chart. You can see the whole chart, and you have to memorize the important one, like carcinoid syndrome. We can see in the bronchial adenocarcinoma or the carcinoid tumor. The other one, that is in the dermatologic disorder. There are various dermatological disorders which can be shown by the patients which have the hidden malignancy. Like the patient with the gastric carcinoma can show the skin presentation with acanthosis nigricans and dermatomyositis. These are the dermatologic disorders which can be seen in the gastric carcinoma, lung carcinoma, uterine carcinoma, and bronchogenic breast carcinomas. The etiology that is given is the immunological secretions of the epidermal growth factor, or it could be immunological. So you have to see all the charts with this, and you have to understand what does means a paraneoplastic syndrome. So it's also very important to understand the pathophysiology of the paraneoplastic syndrome. When a tumor rises, the body needs to use the antibodies to fight it by binding to and destroying the tumor cells. But unfortunately, in some cases, these antibodies cross-react with the normal tissue. So this is very important point. These antibodies which are going to destroy the tumor cell, but these antibodies are going to cross-react with the normal tissue and destroy them, which may result in the paraneoplastic disorder. Means they may be they will present with the different sign and symptom as they are cross-reacting with the normal tissue. And the other may be the antibodies or T cell directed against the tumor may mistakenly attack the normal nerve cells. So the nerve cells, if they are attacked by T cells or antibodies abnormally, then they will present with the particular sign and symptoms, and they will be counted as a paraneoplastic syndrome, because they are not exactly due to the tumor but due to the cross reaction of the immune system. So if the surgeon or the clinician is suspecting the paraneoplastic disorder, so it should be undergo a complete panel of the laboratory studies of the blood, urine, cerebrospinal fluid, to see any malignant cell, because these are the very generally the non-invasive procedure, like blood cytology, urine, and CSF cytology are usually the non-invasive procedure, and the easily can be accessed the malignant cells. If histopathologists or cytologists can pick or able to diagnose the malignant cells, then the particular organ can be investigated for the underlying tumors. So these are the basic laboratory investigations which usually written for these patients which are suspecting for the paraneoplastic disorders. And the further studies are also subscribed by the clinician according to the tumor presentation. So these are the example again I have shown in the slides, and also I mentioned in the table number 7.11 that is given in the Robbins. The same examples are also shown in the table with their major clinical tumors and their etiology. So these are the few examples like Cushing syndrome and SIDH, hypoglycemia, hypercalcemia, Carcinoma syndrome, or hyperaldosteronism. These are the basic examples which I have shown here. Now, coming to our important topic, that is the laboratory diagnosis of cancer. This is very important topic. Exactly, I'm saying this is the last contents of your lecture, but this topic is really important. And in this topic, we are going to discuss the subtopics. That is the first one, that is cytology, histopathology, immunohistochemistry, molecular and cytogenetic diagnosis, flow cytometry, tumor markers, and electron microscopy. And the first one, that is the cytology. In this technique, we are going to see the single cells or individual cells morphology. While in histopathology, the tissue is evaluated for the particular disease or cancers. And in the immunohistochemistry, the certain chemicals are going to express in the tissues with which the surface antigens and antibodies will form the complexes and give us the particular color or the colorful presentation. With this, we are going to confirm the diagnosis. So the immunohistochemistry is also helpful in diagnosing some certain tumors. The fourth one, that is the molecular and cytogenetic diagnosis. Nowadays, the molecular diagnosis is play a very important role in some type of the tumors, because if we have reached the molecules and genetics of these tumor, then the targeted antibodies or the targeted therapy against these tumor will be available, and the prognosis will be much better than the previous one. And then the fourth one is the flow cytometry and the tumor markers. And in the tumor markers, there are some tumors, a certain tumor, which are going to secrete their certain serum or their hormones or their some chemicals into the blood, through which we can able to diagnose this tumor. And an electron microscopy is basically superior than the normal microscope with which we can diagnose some type of the disease, particularly of the kidney or renal biopsies are seen under the electron microscopy, and this is really helpful in the renal biopsies. In the cytology, the aspirate which we are going to take from the tumor is known as the fine needle aspiration cytology. And this picture, you can also take the term is like FNAC. This is the fine needle aspiration cytology. There are the four pictures are given in this diagram. You can see the first one. If we are going to take the cytology of the cervical lymph node from the neck tissue, then the first stage is to palpate the cervical lymph node and then the sterilization with the sprit sweep, and the second one to fix the lymph node with your left two fingers and take the syringe, and then you have to insert the syringe to the particular swelling of this lymph node, and you have to break down and move your needle, and then you have to get to the negative pressure, that is the negative suction pressure of your needle, and you have to take the fluid with some material from that swelling. So this is called the aspirate, and this aspirate, after taking from this swelling or tumor or any, you can see this is the lymph node. Now until this is the lymph node, either it could be benign or malignant, but whenever you have taken this spray, you have to spray it on the slides. And previously, and first of all, you have to form the slides and label with the number, psychological ID, patient's name, whatever you want to label it. So the labeling of the slides is also very important. And then you have to spray this material which you have taken into your syringe. This material is sprayed on the slide, and then the two slides will be then the second slide we have to take, and the material which is put by your syringe will be sprayed with the help of the second slide. So this is the procedure which involves the separated cells and attain the fluid with a small bore needle, followed by the cytological examination of the stained smear. And then the last step is we have to stain these. And then also these slides also needs the formalin fixed sample. In this picture you can see this material which we have sprayed on these slides. Here you can see this is basically the syringe, and with the help of this needle you can see the material is going to spread over this slide, and then these slides are put into this container. This container will contain the formalin fixed solution. This is the 10% formaldehyde solution. Okay, and in this slide you can see these are the single cell morphology. You can see under the microscope. These are the cell borders you can see, and this is the pinpoint nucleus in the center. And if you compare with this nucleus is somewhat larger, and membrane is irregular. And this you can see the cytoplasm. This cell is smaller as compared to this one. So exactly you can see the cytology under the microscope, and you can reach the diagnosis like this smear is benign or malignant. Okay, laboratory diagnosis of the cancer, that is the histological diagnosis. I have already taught you that this basically needs tissue for the diagnosis, and the and the histopathologist is going to give you the diagnosis either it is benign or malignant. But for the particular diagnosis, the laboratory evaluation can only be good as a specimen available for the examination is in a good condition. And there are the several techniques which are introduced these techniques are basically introduced that the histopathologist will able to give us the correct diagnosis. These techniques are the excisional biopsy, needle aspirate, cytology, or the cytological smears. The needle aspirate, the difference between the needle aspirate and cytological smear is that the needle is basically this procedure, as I have told you, this is the fine needle aspirate cytology. The usually histopathologist, radiologist, or the surgeon can do or perform this procedure if they are suspecting any swelling in the body or the tumor which is grossly present in the body. They can perform this type of the procedure. But in the cytological smear, the smears are usually taken from the body cavity secretions like pap smear from the vaginal secretions or the bronchial bulge secretions, urine cytology. These are all of the smears which are taken from body secretions. Okay. the excisional biopsy. And the incisional biopsy means that there's a somewhat difference in the incisional biopsy and the excisional biopsy. The incisional biopsy is usually done for the purpose of the diagnosis of the lesion, and while the excisional biopsy, the two purposes are needed in the excisional biopsy, that the whole lesion is excised with the, and the surgeon also need the particular diagnosis for that. Okay, the histopathological report actually contains the benign or the malignant tumor. For example, you can understand this is the normal duct and this is the benign duct and this is labeled as the malignant tumor. Now you have to focus on the lining of these ducts. These are exactly the alignment and well-orientated cell lining the lumen of the duct. While here you can see the basal lamina is intact here, and the cells morphology, these are the normal cell, while these are the abnormal cell. You can't say these are the normal cell. You see the morphology of the cells. These are the overgrown and going to obstruct the lumen of the duct, and but as you can see here, the basal lamina is intact. There is no any invasion outside this lamina, so the tumor is limited to the these lumen, or we can say that inward growth which can obstruct the lumen. But here you can see the very much anaplastic cell, the nuclear cytoplasm is very much strange, and here you can see the tumor cells have invaded the basal lamina. So you have labeled it as malignant one, and it has a potential to spread locally and to metastasize to the distant organs. So the category like benign, malignant, or the intruding of the tumors, like this is also known as a classification, like the tumors are, the epithelial tumors are known as a carcinoma, while the mesenchymal tumors are known as a sarcoma. And the sarcomas have usually the poor prognosis as compared to epithelial tumors. And from these terms, you can see the excessive proliferation in the single mass and well circumscribed tumors, no local spread in the benign ones. While in the malignant one, you can see the tumors have anaplastic features and they can invade the surrounding tissues. And coming to the immunohistochemistry, the immunohistochemistry is also very important. This is the technique through which the specific antibodies are used against the specific antigens or receptors of the tumors of the particular tissue. And the different types of the chemical reagents are used to highlight these immunoreactions like antigen antibodies, which are expressed on the histopathological tissue. This technique is usually used for the categorization of undifferentiated malignant tumors and to determine the site of the origin of the metastatic tumor, or to detect the molecules that have prognostic or therapeutic significance. For example, ERPR or HER2 expressions are used in the malignant tumors of the breast cancer. Okay, now coming to the flow cytometry, it's basically flow cytometry is a rapidly and quantitatively measures the separate individual cells characteristic, and it's mainly used to identify the cellular antigens expressed by the tumor. And the flow cytometry has also proved useful in the identification and classification of the tumors which are arising from T and B lymphocytes, or the tumor which are arising from the mononuclear phagocytic cells. So this technique is also very important, and this technique is usually using the membrane antigens and DNA contents of the tumor cells. With the help of these techniques, we are picking the particular antigens against these tumors and DNA contents of these tumor cells. And with the help of these materials, we are going to diagnose the particular cancers. And as I already told you, that this technique is really useful in classifying the T and B lymphocyte cells. Okay, there are the several techniques which are used for the diagnosis of the tumor, but the molecular and cytogenetic techniques are usually also using for the diagnosis of the tumor, but these are very useful in predicting the behavior of the tumor. So we can say that the molecular diagnosis and cytogenetic diagnosis are helpful in the diagnosis of malignant tumor, or in predicting the prognosis of the malignant neoplasm, or the detection of the minimal residual disease. We can also find out the hereditary prediction of the cancers. So molecular genetics also play a very important role in the hereditary predisposition to the cancer. This is also a very important benefit of the molecular and the technique, which is it involves the combination of the molecular biology and cytogenetics. And generally this involves the use of a series of the techniques in which the DNA crops are labeled with the different colors fluorescent takes to visualize one or more specific regions of the genome. The tumor markers are also very important. We can see that device with the help of which we can diagnose the disease. They could be, the exact definition is that they could be any cell product. For example, they can be enzymes secreted from the tumor cells. They can be serum proteins, which are showing the excessive levels due to the overproduction of the tumor cells. They can be metabolites, receptors, oncoproteins, oncofetal proteins can be used as a marker to diagnose the presence of the malignancy, as long as it is related to any event during the tumor formation, the proliferation and the differentiation, etc. All these steps will be included in these tumor markers. Or we can say a substance that is present in or produced by a tumor. This is a very simple definition of the tumor marker. The third one, that's a substance produced by the host in response to the tumor's presence. So this can be labeled as tumor marker. Okay, there are the different types of classification of tumor marker. The oncofetal antigens, these are basically the alpha fetoproteins or CEA markers. These are also the surface are like the antigens of the epithelial cells, like the tumors which are usually arising from epithelial origin. In these tumors, these enzymes are raised, that is the CEA in these tumors. And the second one is the tumor associated antigens. These are the CA125. This is basically the marker for ovarian cancer, and the other one is the CA19. This is a pancreatic tumor, and CA15 or 3, CA72 and 4, and CA50. These are exactly marked for the different tumors. And the third one, that is the hormones like beta-HCG and calcitonin. Beta-HCG is a very important marker in the uterine malignancy, while the calcitonin is the parathyroid hormones. These are, we can see in the patients with these tumors, these patients usually show the high C1 levels of the beta-HCG and the calcitonin. So they can give a good prognostic as well as the diagnostic marker for these patients. And the ERPR, as all we know about these receptors, they have a very diagnostic and prognostic factor in the breast cancer, and they are a particular therapy against these receptors too. These therapies are also available against these markers. So these markers have a have a abundant diagnostic, prognostic, or we can see the tumor prognostic markers. Enzymes and enzymes like PSR, PAP. The PSR is the marker for the prostate cancer, and the PAP is for the again for the placental tumor, and SE is again for the neuroendocrine marker, and the PLP is again for the placental tumors. Serum and tissue proteins like beta-2 macroglobulins, these are also play important role in certain tumors. Monoclonal immunoglobulins, paraproteins, and GFP is a very important tumor marker in the brain tumor. The protein like aspartate is a very important marker in some tumor, like soft tissue markers, like in the schwannoma, or the tumor arise from the meninges of the soft tissue tumors, and the paratin and fibrinogens are also access tissue serum or tissue protein markers. Other biomolecules like polyamines and cogenes like ROS and MIC, APL and BCL. MIC is a very important marker in the lymphoma, tumor suppressor gene like BRCA, P53. These are very important genes in the tumor suppressor gene. The therapies are also available against these markers. And also these tumor markers have the diagnostic role, because the level of the markers, the most tumor markers levels alone are often insufficient to diagnose cancer for the following reasons. The TM levels can be elevated in the people with the benign conditions. TM levels are not elevated in every person with the cancer, especially in the early stages of the disease. The median TM tumor markers are not specific to the particular type of the cancer. So in this slide, we are going to discuss mainly the drawbacks of the tumor markers. Okay, so you always remember this: the tumor markers alone are not sufficient to diagnose any type of the tumor, because there are many reasons. Their level may not be sufficient to diagnose, or maybe the tumor marker levels are not elevated in every person. I mean, the tumor is present, but in every person the tumor markers are the level of the tumor markers different with the depending on the person, and especially the stage of the tumor. The tumors with the higher stage having the elevated levels of the tumor. Many tumor markers are not specific to the particular type of the cancer. This is again a very important reason. So how can you judge or diagnose a tumor only on the basis of the tumor diagnosis that this could be the tumor? The level of the tumor marker can be elevated by more than one type of the cancer. Again, this is also a serious problem. So the tumor marker, always remember this point, is that the tumor marker is not the key diagnostic tool that can be a complementary sign to the clinical findings and the medical imaging. Like examples are the alpha-fetoproteins and the human chorionic cancers, beta-HCG hormone. With all of this, I have tried my best to teach you this topic. If you have any query, then you can ask in your GCR Google Classroom. Okay, Allah Hafiz.